We also have a mortality committee that we formed with our clinical leaders. We look at the most problematic cases and say, what are we going to do to fix this so it doesn't happen again in our hospital? Now that what we've done is we've armed everybody with good data, and we hold them accountable to saying, you need to have improvement based on the data that you have. So here's what the report cards look like. So this is a test, this is an example one. You can see that it shows for this could be medicine, for example, and this shows them the hospital's numbers overall. So you can see it says, here's the number of deaths you had, here's the number of notifications that were sent, here's the response rate that we got, here's the deaths that have one review completed, here's how long it's taking your doctors to fill it out. Again, this is example data, but you get it. So the quality lead in that department can see how his or her doctors are doing in filling it out. They then get information on what kind of complications were reported in the patients that died here. So they have a sense of where the problems are in their service and what's killing patients on their service. Now these aren't all preventable, these are just the complications that killed them, okay? And then they get a list of the patients who died and what the preventability rating was. Remember I told you, so if anything gets a 3, 4, or a 5, we expect them to investigate and get back to us telling us what they did to help fix that problem, the quality directors. And again, we put this data out to them once a month and we ask them to look at it. And what's amazing is they care about quality and safety, so they actually welcome these reports. And if we don't send it to them, they actually ask us questions saying, what happened, what's going on here? So they're actually very interested in all of this. And they also get all the text, anything that the reviewers typed in, they can read all the comments. So let me give you a case example of what our mortality committee is, one example of one problem that our committee was trying to fix. It's a simple thing. So we had an elderly gentleman who had type 1 diabetes and high blood pressure, okay? He came to our emergency room because he was short of breath, he couldn't breathe. And after a plane flight, and they found out that he had a large blood clot, a PE, in his lungs. Okay? Turns out he was very obese, he was overweight. He was 320 pounds. Okay? They put him on 120 milligrams of Lovenox twice a day. Now it turns out the Lovenox, when it first came out, we used to tell people you can't give them more than 120 because all the studies were done on people who were less than 120 kilograms. Okay? They didn't put this guy on unfractionated heparin, they put him on Lovenox, and they put him on 120 maximum. But if you were going to try to put him on his weight per his dose, he needed about 160, I'm forgetting the number, he needed about 140 milligrams or 150 milligrams of Lovenox. So they didn't give him the maximum dose because, again, the old guidelines used to say 120 is the maximum. Everyone with me? So, and they didn't order 10A levels to make sure that he was getting enough drug. They just didn't do enough checking because they thought, this is the maximum dose, there's nothing else we could do. He got admitted to cardiology because they were going to try to put a catheter in his lungs to break up the clot. But he actually arrested, he coded and died that night. One of the reviewers gave it a rating of 4 because that reviewer was worried that this patient didn't get the right care. So there's a problem here. Okay? And they were worried about the fact that the Lovenox dose wasn't correct. We wouldn't have heard about this, I can tell you, had the reviewer not told us about this. You can imagine how we might not have heard about it. So our committee heard about it. We sent it to cardiology and said, you guys need to discuss this case and let us know what you thought was wrong here. They discussed it. They agreed that the dosing wasn't correct. They weren't sure if it led to the patient's death or not. They weren't sure. They just said even with a higher dose, he might have still died because it was such a big PE, but everybody agreed that the dosing wasn't done right. Just wasn't done. So our committee is now working to change how it looks on the computer screen when the doctors order it. It turns out that we had to first update our hospital guidelines. That took a while. Then we had to go to our computer people to fix the computer, and we're still not done talking to them because that took a while. But this is how we're trying to fix the problem, so that now when you go to order Lovenox in a patient, if they weigh more than 120 kilos, you get an alert saying, don't do it this way, you need to call pharmacy to get the dosing done right. This is a simple example of how we're trying to change the system so the same thing won't happen again. And I can tell you, I hope I didn't make it sound easy, because this hasn't been easy for us. It's amazing how much it takes to bring a little change like this. Any questions? A lot of challenges. So I've described the ways to improve mortality, and I've told you what we're doing. We've noticed there's still a lot of challenges, and all the hospitals in my country still struggle with this. One is getting providers to believe the data. As we talked about the risk adjustment, people don't believe we've risk adjusted the data well enough. So we continue to work at that. We still tell people that's true. It's hard to compare hospital A to hospital B, but there's no reason that hospital A can't get better from one year to the next year using the same risk model, right? We can all still get better. People still worry that the data, as much as we collect it, doesn't really bring changes. Getting people to talk about the death after it happens. Most of us feel bad when patients die, and we don't want to talk about mistakes if they happen, so getting people comfortable with it is still a big cultural change that we're working on. And we like to think that the way we've done it at my hospital, which is just asking everybody routinely to do it, they all understand it's just a way of doing business. Always just talk about it after it happens. Don't only do it on the difficult cases. Do it on every case. Again, fostering a culture of safety, as we talked about, and of course implementing the change. Easier said than done. I also want to so we did a big focus here. So again, what I mentioned was that risk-adjusted mortality is how we tend to get graded, right? It's your risk-adjusted mortality is a function of how much you observe, what your actual rate is, over your predicted mortality. So I spend a lot of time talking about how do you reduce preventable deaths. But that's not the only strategy we're working on in our hospital to reduce our hospital's mortality. There's two other things that we're doing. And I'm not going to talk about them in detail, I'm just going to tell you at a high level. One is reducing non-preventable deaths. So what do I mean by this? This is what I talked about briefly earlier. There's a lot of patients who get admitted to the hospital even though they're very sick and there's nothing we can do for them, or they're on hospice. We're trying to do a better job of make hospice available in the outpatient setting so that patients don't come into the hospital, because it turns out if you survey most patients, they don't want to die in the hospital. Yet the majority of our patients still die, our people in our country still die in the hospital. So we're trying to find a better way to improve hospice for patients in the outpatient setting so that when they get sick, they don't have to get admitted. And the other thing that we're working on, which drives me crazy, is that the predicted mortality, how you do the risk adjustment, is based on what gets coded on the bills. So we need to also make sure that when we do comparisons to other hospitals, that we're actually documenting all the other complications correctly. Because if you don't document them, it's hard to compare the hospitals. So a lot of hospitals in our country now have a lot of clinical documentation teams that are working to make sure that all the problems that patients have get documented in the chart and get coded, so that when we get compared to other hospitals, it's done on a fair level. A lot of people argue this is busy work. I think it is, but how else do you benchmark properly?